So I think we'll go ahead and get started. Good afternoon, everyone. I'm Mark Mitchell. I'm with the National Medical Association, and I also am the State Affairs Director for the Medical Consortium for Climate and Health. So what do you think of the conference so far? Yes. So we are moving on to our second half of the conference, and so we're excited about this. So I'm moderating this session, which will be an overview of the U.S. National Climate Assessment and Health. And so we have a speaker, and then we have two people reacting to that. So first I will introduce our main speaker. Many of you know him. Dr. John Bellvez is a physician and public health specialist. He's a senior advisor to the director of the National Institutes of Health, National Institutes for Environmental Health Sciences. And he advises in the area of environmental health services and public health. He leads the NIEHS's efforts on climate change and on human health. He's the Health and Human Services Department's representative to the U.S. Global Climate Change Research Group, and he co-chairs the Climate Change and Health Committee of that organization. He's authored numerous articles and given many lectures on climate and health. He is also involved with transportation-related air pollution. He's also authored numerous articles about toxic effects of chemicals. And he's also talks about the regulatory approaches to protecting susceptible subpopulations. So today he's going to talk about the update to the climate assessment for 2018. So with no further ado, Dr. Bellvez.
Thank you so much, Mark, and good afternoon, everybody. I was going to start off by saying I'm here from the federal government, and I'm here to help. But actually what I wanted to say was a little more heartfelt, which is I'm here from the federal government, and I really want to thank you for all the help that you're giving me, in part by coming back quickly from that coffee break and whatever cookies were back there, but more importantly, for being in this room today. I've been working on climate change and health issues for 24 years, and the day that I thought I would ever come to a room that would be filled with health professionals who have taken off a day just to come to a conference on climate change issues was kind of a dream back then, and so I feel like I'm living the dream now, and I'm very excited. So I thank you very much for being here. Oh, this isn't the thing that I was supposed to do, is it? It looks like a pointer, but I had it on the other way around. What did I just do? It was upside down. Here we go. This is going to be better. So it's been a day of wonderful talks, and I think that one of the things that you can take away from the talks is that we are in a very different place now than we were 5 years ago, or 15 years ago, or 24 years ago for those of us who have been in this for a while. And some of the progress has been things that have actually gone on in the federal government, and that's partly what I'm going to be telling you about today, is the work that's gone on these very authoritative scientific assessments that I think are a great asset for everybody in the room. And then a lot of this is going on that you're representing in the universities, in the state level, at the community level, and the city level, and in our medical societies. But these are just some representative things that 5 years ago you would not have seen. On the top left is an assessment from the CDC of 18 different programs, 16 state and 2 cities, where they have been paid to go out and do a climate health vulnerability assessment and come up with an adaptation plan. And this is the compendium of all of those and the evidence base, not just for what might happen, but the evidence base for how should the public health and the healthcare communities actually take action and protect people. The top right is the climate health assessment. This is a more than 350-page compendium of the state of the science that was published in 2016. I'll be saying more about that in a little while, but to think that the Global Change Research Program would devote its resources to that kind of authoritative tome just on health issues would not have been something we would have seen 10 years ago. The bottom left is just the emblem of the Belmont Forum, which is an international consortium of the world's climate science funders, which voted very strongly last November to take up health as the topic for its next collaborative research action. And we're going to be having a workshop here in New York. Oh my gosh, must be near 4 o'clock. My brain isn't working well. We're going to be having a workshop here. It's not going to be in Arlington. It's going to be in Washington, D.C., of the funders to come together and shape and scope that research funding announcement. And then the bottom right is where we all are today. It's the medical consortium, and to think that we have 21 different medical societies now all coming together on this singular issue in the United States to both protect patients but also take action to mitigate climate change is a huge, huge new world. What am I pointing at? Before I launch into the discussion of the assessment, I just want to remind everybody that what I'm talking about, that these national climate assessments are not an executive order. They're not something that happens at the whim of the current president. They're actually a congressional mandate from the Global Change Research Act of 1990, which stipulated that there needed to be a quadrennial assessment of the current understanding of both climate science and the impacts of climate change. Now, 1990 was 28 years ago. You can do the math. I'm about to tell you about NCA 4. So we haven't been doing great as a global change research program and doing this every 4 years. But the good news is that 2018, which is when we're hoping to release NCA 4, is actually 4 years after NCA 3, which came out in 2014. So we are, and the point is, we have a congressional mandate, and we are actually, in 2018, fulfilling that congressional mandate this year, we hope, to put out the National Climate Assessment. And of course, everybody in this room is a stakeholder to assure that that assessment, that will of the people as expressed by the Congress, actually does happen. If there's one thing, how many people, show of hands, how many people have downloaded a figure, a slide, something useful to them from the climate health assessment? Oh, I don't need to talk anymore. This is the best room I've ever done. We're at about 60%, I think, by just my visual. So a round of applause to you. For the 5 people, for the 10, 15 people who have not yet, please write down this URL, because this is the most comprehensive set of scientific assessments, figures, fact sheets, translated information that you can find now on climate change and health. And there's the URL at the bottom right. I want to just take a couple of minutes and talk about some of the things that were special about the GCRP special report on the impacts of climate change on human health in the United States, which is its full title. We call it the CHA, or the Climate Health Assessment. This is one of the key figures for it, and I just show this to you now to emphasize that when we talk about climate change and health, it is impossible to extricate that from a discussion about the social determinants of health, which is where so many of us live, or even about the other kinds of environmental impacts that are going on both globally and locally that climate change interacts with, whether that's land use change, other changes in ecosystems, nitrification, things that aren't necessarily related to climate change on that left side that actually are very important for influencing how climate change impacts health. At the core is this causal chain that starts with increased greenhouse gases, which are not seen in this diagram, leading to changes in climate manifested by temperature, precipitation, extreme event changes, through these specific exposure pathways. And this is one of the important things about the climate health assessment. It is focused on exposure pathways as a way to both understand why things are happening and to be able to intervene upstream. It's not focused as much on the clinical outcomes at the bottom, but a little bit more on how do we intervene in terms of preventing exposures and reducing the impacts through adaptation in that way. I'm going to go very quickly through the main findings then that are organized by these exposure pathways, and I want to highlight two things. First, this 2016 climate health assessment was the first authoritative federal effort to put a number on climate change health impacts, to actually quantify what we can quantify. Knowing there's a lot we can't quantify, but until we start and until we demonstrate what we can and what the gaps are, I don't know if that's in this room or just my hearing aid, or until we put that number on, we're not going to build the science to be able to get our models and our assessments stronger and stronger. So it quantified for the first time the net impacts in the future of the differences between increased summertime mortality from heat waves as well as decreased wintertime mortality from warming of the winters. So we were criticized in the past for only looking at one side of the coin. This looks at two sides. It provides some quantitative modeling of future of difficulty attaining ozone standards. So what's the climate penalty, if you will, from the fact that warmer atmosphere will increase the rate of ozone formation. So given the same amount of emissions, you get higher concentrations, peak concentrations of ozone during the day. It quantifies that. On infectious diseases, our limits of quantification right now are mostly looking at exposure. This morning we heard about the Lancet countdown and those indicators. A lot of those were exposure indicators. How many more heat wave days will we have? Population-weighted heat. The climate health assessment looked at West Nile virus, it looked at Lyme disease, but the actual ability to quantitatively estimate incidence in the future is beyond us right now. There's too many complex interactions between human behaviors, land use change, et cetera. But what the assessment does do is to look at changes in range and the length of season, if you will, for ticks. Similarly, for waterborne illness, it was very difficult to come up with a quantitative estimate of the incidence of waterborne diseases. What we were able to do was to look at quantitative assessments of the likelihood of high levels of Vibrio vulnificus, which is a waterborne pathogen that people get through food in coastal areas because of changes in the temperature of the waters. One of the things that was seen for the first time in a federal assessment on health was a look at the direct impact of CO2 fertilization on the nutritional value of crops. This is a whole area of science we can't go into in detail, but there's a lot of concern, especially in areas that are already on subsistence kinds of food insecurity status and very dependent on food crops, subsistence crops for food. When you increase the CO2, you tend to decrease protein content as well as some vital minerals like iron, magnesium, et cetera, and the actual quality of the food goes down. This was the first look at that literature. Another important first for the climate health assessment was an expanded discussion of the mental health consequences. The evidence base is really strong for post-traumatic stress from severe disasters. We heard some discussion of that this morning. The literature that our friends from the American Psychological Association have been really good at pulling up, the American Psychiatric Association, on other aspects, other mental health aspects of climate change, including what we all just heard about a little bit in the last session, our own despair and the despair of our children, the despair of the general population from either the anticipated loss or the actual loss of beloved environmental landscapes, glaciers, coastlines, et cetera, addressing those kinds of issues for the first time. And then lastly, another important thing about the climate health assessment was a very detailed look at the different vulnerable populations, the different groups that are at higher risk, expanding that, looking at the different ways in which specific groups are vulnerable, again, to be able to inform interventions to be able to protect them. So those are the highlights. That's the quick run through the climate health assessment. One important point is that the climate health assessment of 2016 was really focused on impacts. It didn't talk a whole lot about what to do. It didn't talk about adaptation interventions. It was very quiet about the co-benefits, or what we call co-benefits, the ancillary benefits that accrue from reducing fossil fuel combustion if you're doing that to reduce greenhouse gases, We also tend to reduce the air pollution. That is the major killer. It didn't talk about that very much. So that's the climate health assessment that came out in 2016 with again, some comment about the limitations in its scope. I'm going to tell you a little bit that I can tell you about the fourth national climate assessment. So our climate health assessment in 2016 was a special report just focused on health, sandwiched between these big third and fourth national climate assessments that have dozens of chapters on all sectors. This year, we were a little more explicit about making the National Climate Assessment a two-part document. So what might have been put out as just a special report on climate science is now being labeled the first volume of the National Climate Assessment. So that's just climate science focused. What are the observations? What do the latest models tell us about climate science? That was released in November of 2017, which was a remarkable fact. You can see here the congressional mandate, and that that Volume 1, the Climate Science Special Report, was really about the current trends in global change and what the models are showing. The Volume 2, which we anticipate coming out in December 2018, is kind of the big kahuna, right? That's all of the different sectors. And I'm going to tell you a little bit more about what is special about this upcoming volume. So this is just a timeline to let you all see it. You can't read it all, but the red part is where we are. So we're pretty far in the process. We're on our development of our fourth iteration, our fourth order draft. We've just completed a National Academy review and an extensive public comment. There are very few assessments on climate and health that undergo a National Academy review and extensive public comment. So that gives this document some unusual weight, authority, and credibility. The process from here is going to be now within the federal government. There's going to be a technical science-based review coming up in the next couple months. We've just, in the last couple of weeks, finished the revisions in response to the public comments and the National Academy. There will be this interagency within the government technical review, a response to that, and then a final agency clearance process. And it takes months then to get it into the layout. So we're hoping to get it out December of this year. What I'm going to share with you is what is already public. So these are the key messages that were in the third order draft, the public draft that went out for comment in December. I'm not going to spend a lot of time. There's a lot of words. The words are going to change, I will tell you that. But I think the main point is that our key messages in the fourth National Climate Assessment are pretty resonant with the key messages from the third National Climate Assessment, which resonates with the George Mason Climate Change Center's communication dictum: keep your messages simple. Climate change is happening. It is affecting people's health now. There is something that we can do about it. And also, people are different in their vulnerabilities, and not everybody is equally vulnerable. Those are the essential key messages. We had 3 in the third order draft. I will, I think, divulge late breaker. There will be 4 because we actually raised the issue of vulnerable populations or people at unusual risk to the level of a separate key message again. So the second key message in the third order draft was this message about adaptation policies and programs and the importance of incorporating climate change into other sectors, planning and design. And then the third is this issue about the benefits, the health benefits that accrue from action. One of the things that's different in the fourth National Climate Assessment from previously, there's 2 ways to think about it. One way is to look at what would happen if we have really bad climate change in terms of heat mortality, air pollution, and diseases, and then what would happen if we really took strong action to mitigate climate change, didn't have as much temperature increase. What would the burden of disease be then, and what are the avoided harms? So that's a benefit of a health benefit of climate action, and we have an assessment of that that's been done that's incorporated into this. In addition to looking at what are the short-term direct benefits from reducing air pollution if you stop burning fossil fuels, or if you do other things to mitigate greenhouse gases. So 2 different sides, 2 different aspects of the health benefits, putting things into an economic health turn. So what's new about the NCA 4? One of the things that's really important about this is the NCA4, compared to all the other national climate assessments, has had a very, very strong regional focus. Regional chapters are about 20 pages. Our health chapter is about 6. So there's really rich region-specific content, and 4 or 5 of the regions have a lot of health content. There's incorporation of these quantitative economic analyses, so things are, a dollar value is put on many more things. There is, in the NCA4, compared to everything that has gone before, more explicit discussion about the role of the healthcare sector itself, both in terms of responding and reducing the burden of disease, but also in terms of the sustainability of and greenhouse gas measures that the health sector can take itself. And then, very importantly, in this NCA, health is not just in the health chapter. There's 6 pages of health chapter, but there is extensive discussion in health in other chapters, which I think is a huge advance in terms of the role of the health community in the climate advocacy community, climate science community more broadly. So Air Quality International, there's a chapter on sectoral interdependencies, which is as complex as the title sounds, and built environment, as well as some other chapters. Just very briefly, I want to tell you about some other things that are still going on within the Global Change Research Program on health and climate change. We have an ongoing effort to enhance our predictive capability. We've had workshops, and we're producing a report on predictive capability for infectious diseases, especially vector-borne diseases. We have a process going on now to look at the vulnerability of healthcare facilities and health systems in the setting of disasters, and we're working very closely with the disaster management community on that. And we're also looking at doing a similar kind of interagency technical modeling initiative on air quality impacts, looking at both climate-sensitive toxic pollutants as well as pollens. I just want to close with some other resources that we have that are still available to you on websites that are still very much alive and kicking. This is a set of educational materials that we developed at NIEHS. What's up there now is for K through 12. We have just recently expanded that to an international version for K through 12, but also domestic and international versions for healthcare professional students and public health students. And this is a climate change and health literature portal. We developed at NIEHS this tool to support the 3rd National Climate Assessment, the climate health, all of the assessments that I mentioned to you. We help provide the bibliographic database. We've now curated this and tagged it so that you can go in and look under key terms for literature that you are interested in on a global basis. It is only up to date now as of 2014, but we hope that by the end of this year we will be up maybe through 2017 if I can get the funding, at least through 2015. So in conclusion, yeah, it's a tough time. And we talked about the despair that we all sense when we think about, as was said in the last session, the impacts that have already happened, the impacts that we feel are unavoidable. But things have not come to a complete halt in the federal government, and we are still making very significant progress. And hopefully, you will all be part of the process of making sure that this NCA4 comes out in December and that we get really good recognition for the health content of it. So with that, I'll close and look forward to the discussion. Thanks very much.
So thank you, John. We really appreciate that review of the NCI from the 3rd NCI and the preview of the 4th. So we have 3 responders to that. And the first of the responders will be Teddy Potter, and she's not only a doctor, but she's also a nurse. So even though I've never met her before, you've got to trust her. She's with the University of Minnesota School of Nursing. She's coordinator of the Doctor of Nursing practice there in health innovations and leadership. Without further ado, Dr. Potter.
While she's pulling up my slides, one of the great parts of speaking to a group like you is that when you speak to other scientists and you throw up a bar graph or a pie chart, they see numbers. If I were to throw up a bar graph or a pie chart, you see patients, families, communities, and populations. And that's what we'll be talking about. This report does a lovely job talking about how it impacts the 6 different regions. And I'm just giving you a snippet on how it's impacting one region. And that's where I'm from, is the state of Minnesota. So if you don't know much about our land, we are walking upon the sacred and ancestral grounds of the Lakota, Dakota, and Ojibwe people. Many of the rest of us are immigrants, started with Scandinavians, Germans, and Irish, but more recently we have many immigrants from Laos, Cambodia, the Hmong people, Tibetans, and most recently the Somali community. And one of the things that unites us is you cannot live in a difficult land and survive if you're not aware of the patterns. So we are consummate pattern readers. Not just weather readers. All our little kids can look at the sky and tell whether it's going to rain or whether it's going to snow. That's just part of our survival kit. But we have hundreds of years of information in our bones about how to survive a harsh climate. Because not only did our livelihoods dependent on it, our very lives depended upon being able to read these patterns. And what's particularly chilling right now is we do not have patterns. Our traditional patterns that have lasted for hundreds of years have disappeared. And we're now seeing new patterns, which are precipitation changes and heat changes or warming changes. Here's the indications of the annual temperatures in Minnesota and how they've changed over the years. And if you look at the last decade, you can see these remarkable heat events in Minnesota. Ironically, we are having warming winters and in some parts of Minnesota cooling summers. So our heat isn't happening in the summertime, ours is happening in the wintertime. So we're having ice and people falling from ice because we've never had ice. We either have lots of snow or lots of snow. And now we're having more ice. But we're one of the states that's warming the fastest in the winter. But, and here's just showing how winters are really our key point here. But I don't want you to feel too sorry for us, because these wobbly jet streams are causing us to draw down all the cold air from the Arctic. So we do have polar vortexes, far, far more than we'd like to see, where it can get down to 26, 30 below, and we can no longer send our kids to school because of the dangers. We're also seeing a rise of precipitation, and these, like many of your areas, are coming in fierce events versus the nice gentle rains as they come in the past. As a matter of fact, 7 of the 15 mega rain events have occurred since 2002. Even that would be wonderful if we could get used to that being a pattern. Here's a major flood of 2012 up in Duluth, Minnesota, up in the Iron Range. And our infrastructure is not built to handle these massive events of water. And again, if this was a pattern and a predictable pattern, we adjust to these things. We're very good at this. But this is 2012 Minnesota. Half of the state was a FEMA declared drought state, and half was declared a FEMA declared flood state. So it's very, very difficult for our people to adapt. I looked at this little chart which has the insignias of all the things that are going on, and we are a poster child for this region. What we're seeing is a rise of pollen, which is up to 22 more days of pollen and ragweed season extended, which might not sound like a big deal unless you have asthma or allergy-induced asthma. It's a very, very difficult situation in our area, and our people who have underlying respiratory conditions are really struggling. Similarly, we're also seeing a rise of West Nile and also Lyme's. There's multiple factors that contribute to those two vectors coming in, but climate change certainly is having an impact. We're seeing changes in our food and water quality with rising mercury in our fish, algal blooms that aren't just related to pesticides, they're related to the heat and the warming of the water. And then I would be very remiss if I was in the Great Lakes region and didn't talk about, just like when a body's natural resistance is down, parasites and opportunistic infections come, we're seeing opportunistic invasive species entering our Great Lakes, and these are the zebra mussels. We're seeing more and more despair in our region, and the sadness around what this means to lose our patterns. We're people that are deeply, deeply connected to our lands and our water and to our crops and our food. And we're seeing this despair, this nostalgia when the patterns are changing. So what are healthcare providers doing in our area? We're marching. We're marching for renewable energies. We're shifting our curriculum for our health providers. We're hosting a big conference, interprofessional conference, which is coming up on April 20th. An interprofessional conference, as I said, at the Science Museum. We even have our senator coming and being on a policy level. We're talking to anybody that will listen. Oh, and did I say marching? We're marching a lot. So I want you to know we are your bold north. We know what's coming, and we're doing everything possible to stop it.
So thank you, Dr. Potter. So we've heard about Minnesota, and next we have a speaker from Florida. Dr. Cheryl Holder is an internal medicine physician who's dedicated her career to serving the underserved in Miami, Florida. She's also an assistant professor at the Herbert Wortham College of Medicine at Florida International University. And so, without further ado, Dr. Holder.
Good afternoon. I'm glad to be here and speak with you. One thing that's great, I'm speaking in front of a lot of docs and folks who know the data. So I'm really going to just cover 2 slides. I'll just do this.
Either one.
Okay. Key message number 1 from the National Climate Assessment says, risks are not experienced equally. And as a physician who cares for the underserved for most of my career, that has been real to me pretty much every time I see a patient. Risks are not experienced equally. And so for climate change, when it impacts the population I serve, you already know the data. You've heard 4 times more African-American males, young kids with asthma, just more of everything. Sometimes my students, the medical students, hate really just seeing all of this data. If they're the black students, it's always, oh, black folks, worse and worse. But that's the reality. Risks are not experienced equally. So I'd like to start with a case because she is my typical patient that brought the message home to me. And so as you fight for climate change and fight for all the general folks, key message number 1, that we do have to look at solutions that will address the folks who are not experiencing the changes equally. And Ms. Anna May, I worked in a community center, poor blacks, poor Hispanics. She worked all her life. In Florida, most of the low-income jobs are in the hotel and the service industry. Retired at 62 when they kind of kicked her out anyway, so she took her early 62, which puts her barely at the poverty level when you get your Social Security income, with the usual hypertension, diabetes, hyperlipidemia. She had mild intermittent asthma, was obese, and had multiple medications, and was on albuterol. I don't know if you know, these drugs are, the medications for diabetes are somewhat controllable. The medications for asthma, COPD, is pretty expensive. So she was doing well. She's always done her best, but she started coming into me. She came in this time for refill. And she had, based on my assessment, has shifted from mild intermittent over to needing one of the steroid inhalers, which is going to be other cost. Now, as you guys know, and I told the last group, as a doc, we know in primary care, it's usually that last few minutes when you're about to wrap up, they say, oh, by the way, doctor. For her, oh, Dr. Holder, could you sign this form for me from FPL? Florida Power and Light is our wonderful service of electricity, and everything is electric in Florida, your heat, your air conditioning, your stove, everything. So these bills are high, and especially for poor people, it's a larger percentage of their incomes. So her bill went up, and she was about to be cut off. And I'm like, what happened? She just had to use a little bit of her fan. She had to use her air conditioner. She couldn't use the nighttime was hot anyway. She lives in Opelika, which is high crime, so it's pretty hot, and her asthma was worse, and she had to use more electricity. Now, Florida Power and Light says, I can't sign as a doctor approval because somebody's poor and can't pay their light bill. They have to have life-saving equipment. She had no life-saving equipment, so I can't really sign this form. But of course, I tried the social worker, gave her a steroid, long-acting asthma, but she is what we are fighting for. A question?
Repeat the question.
Is there air conditioner life-saving? Not on the Florida Power and Light guidelines. It would be oxygen concentrators, nebulizers, those sort of things.
My point is, air conditioners are the most important thing for preventing stroke, and heat impacts are the largest mortality during extreme.
Agree, but you know, I have to double check. I think it was a fan that she had in her house, or fans. But the form that I have didn't put those things on, and it would be a huge battle. So what we do, I don't think air conditioners listed on the form, because they had a list of the equipment. But that may be something we could advocate for Florida Power and Light. But I don't think she had air conditioner, you tell me. She had fans. Most of my patients have fans and not AC in the houses, because these are built in 1940, so there's really no central air, and you'd have to retrofit your windows. But generally, this is our patient that we're dealing with. And what do? We know about the hottest air. I won't repeat all of that. Florida, this data, 2017 is bad. Nighttime temperatures in particular are pretty bad for us in Florida. And if you know all the complaints and all the illnesses we are going to see, and the Zika and everything else we're dealing with, most of my population, there's a Florida Resiliency Committee that's trying to come up with a Florida plan, because if you look at the areas that are most impacted, about 900,000 folks, mainly Black and Latin, live in some of the highest impacted communities, and their poverty level rates are high. So the resiliency group is, how are we going to do something about health effects in the population, and just more than health, the overall resiliency plan. But if you look at what's going on here, this is the big issue in Florida. It's not so much the people, it's the $2.9 trillion real estate that is at risk, that impacts primarily the upper income folks. And if you look at, again, the things that are used to mitigate, it's not about the people. We are very much aware of what's happening, and when Florida voters vote themselves a tax increase, you know they are aware. And in November 2017, we voted in Miami to get a $400 million general obligation bond, and almost half of it is going to be an infrastructure to address flood prevention and sea level rise, because we are experiencing king tides, there's flooding in Miami Beach, there are a tremendous amount of changes that are happening. Governor Scott, who does not recognize climate change, doesn't talk about it, he is still allocating funds to do things as he calls beach renourishment. Why did the beach need to be renourished? We don't talk about that. Lake Okeechobee, toxic algae bloom. Why did this bloom happen? But so resiliency is happening, but again, in my population, you will see nothing talks about in resiliency for people and nothing for poor people. So as we move towards the changes, if we are to take the key message number one, that this is not going to impact us equally, and there are populations that will be more vulnerable, and they outlined it in key message number one, and which is the population that I happen to serve, then together we are going to have to get more data, our electronic records, when the asthma, because everybody wants data to prove this. My patients, like, you know, you researchers are always studying this stuff, and nobody ever has any money. You study it, you make money studying it, and I'm still short of breath. So I hope for climate action that we will do more and have some solutions and tap into all those resiliency dollars for our patients. Thank you.
Thank you, Dr. Holder. All morning you've been hearing from doctors and nurses, and this is all very, very important, but in order for us to get things done, we need to be working not only with other medical people, but across disciplines. Our next speaker is Adele Houghton, who is a licensed architect and lead accredited professional. She's also a public health consultant in Texas, and she's the president of BioSitu, which is a strategic consulting company dedicated to using public health research and data to inform climate change and green building policies and practices. So without further ado, Adele.
Thank you. Well, thank you. I'm going to talk about a project in rural western Kentucky. There is a report that is freely available on the health department's website, and I'm happy to give you all the URL after this talk. If anyone's interested, it goes into a lot of detail similar to what we've heard in the previous two presentations. But what I thought I would do is kind of shift the conversation just a little bit for these last few minutes and talk about how do you go from a large assessment of how the climate is changing in the U.S., such as the National Climate Assessment, and then actually use it as a catalyst to make changes on the ground through policy work and programs with healthcare providers. So to start out with, this was a project with a local health department in rural western Kentucky, as I said. And we started the project looking at the third National Climate Assessment and recognizing that there was identified a gap of metrics to understand the vulnerability of rural communities. And so we thought this was a good gap to start trying to fill and sort of see what kind of research was already out there available, what kind of data sets were available that we could use, not having to create anything new, that would allow the health department to start working on climate and health issues. And so just to get started, for those of you who aren't familiar with the vulnerabilities of rural populations to climate change, there are a number of them. Demographically, rural populations tend to be more elderly, lower income, lower education levels. They spend a larger percentage of their income on medical care, but they have poor health outcomes than their urban neighbors. So age-adjusted mortality rates are higher, disability rates are higher, chronic disease is higher. The built environment, of course, is different. So there's a possibility of being isolated during events. The infrastructure is more fragile and not as redundant, and so you could get trapped during or after an event. And the types of exposures from the environment are different because of the agricultural nature of these locations. The district that we were looking at in particular is a 7-county district in northwestern Kentucky. All of those counties are identified as more rural than the U.S. national average of 19.3% rural population. 2 of those counties were identified as 100% rural, but there also are 2 population centers in that 7-county region. So through this process, we were able to both identify vulnerabilities and indicators for rural populations in that area, but we were also able to compare, to some extent, what were the differences in vulnerabilities amongst the more urban populations versus the rural populations. The methodology that we used was based on the CDC BRACE framework. We started with the National Climate Assessment and the Human Health Assessment report that John told us about, and used that to develop a short list of environmental hazards that were focused on the southeast of the U.S. We then looked for state level, regional, and local data and reports. For example, Kentucky has an adaptation report for the state. The region has a hazard mitigation plan, and we were also able to get data directly from the state climatologist that was specific to those 7 counties. With that information, we developed a list of indicators and identified our primary hazards that we were going to focus on. We validated all that information with our local subject matter experts, and then came up with a set of recommendations to help inform the ongoing community health assessment, health improvement plan, and then also to help build out the newly created Kentucky Environmental Public Health Tracking Program, which was the source of the funding. So the three hazards that we looked at were extreme heat, drought, and flooding, and I think we've heard a lot of great anecdotes about all three of those hazards, and I'd say that you'll see a lot of similar information in the report, but just more specific to rural Kentucky. Once we had identified those hazards, we created indicators for each one of them at the county level. And so to look for it, we kind of did the same kind of methodology as developing the hazards, starting with national data sets such as National Environmental Public Health Tracking Network, moving down to the state tracking network, and then down to the county and sub-county level, and in some cases looking for data sets outside of traditional public health sources. This is just a snapshot of the indicators by county, and again, you can go onto the report and read them through them in more detail. But what I wanted to point out was the kind of color coding. So they are divided into environmental exposure, human health outcome, population vulnerability, and environmental vulnerability by county, and they're color coded. So the ones that are in red, the metric for that particular county fell short of a metric that could be a reference from Kentucky and from the national data sets. If they're in the orange section, then they fell short of one or the other reference, and then if they were green, then that county indicator was an improvement over the other two references. So based on that information, we created a number of recommended actions, many of which involved cooperation between the health department and local and regional medical providers, doing things such as sending alerts out when extreme heat or flooding events were happening, starting to collect some of the data that people have been talking about that maybe aren't being collected during these emergency events, and starting to use that information to track and also to create communications that then go back out to the population to explain how they can protect themselves during and after these events. And a lot of that, the communications information sort of circles back to that federal level information through the climate assessment, through CDC, et cetera. I want to thank our local subject matter experts without whom this project would not have been successful. And then I'll just leave the information, my contact information of my colleagues at the Green River District Health Department in case you want to learn more about the project.
So thank you all for our speakers. Why don't we take a couple of questions if we have a little bit of time. Sir.
Dr. Bellvez, what can we do to help this report come to fruition?
Keep an eye out for it. Look, towards the end of December, or early January, it should be out, and call your congressman if it's not.
There aren't any letters or anything we can do before that to help the
I'm optimistic that this report will come out. There may be, it's been under actually, even though it seems like it's taking forever to get this done, it feels from the inside, and those in the room who are in this, like it's at breakneck speed. And so, because everybody has another job who's doing this for the most part. And so there may be some delays as we go through the iterative final reviews, but it's on track. So all I can say is keep an eye.
Yes, ma'am.
So, Dr. Holden, I feel like I owe you an apology for interrupting your presentation, but I think it's an important way.
I'll repeat it.
I will repeat it.
I think it's an important way to connect the experience that we have directly with patients, identifying the particular vulnerabilities of patients who are poor and don't have resources, but then making the healthcare risks, particularly of heat, really apparent, and then connecting the dots to policy issues. And I wasn't meaning to be glib about saying that air conditioning is a health device, but we have to be the ones who say heat is a huge risk. It is more risky for vulnerable populations, and the safest way to protect from those is to protect from heat
I agree 100%. She's saying that air conditioning is key for one of the resiliency, and I agree. And that's where funding comes in. But in the patient I have, if you look at the guidelines currently, yeah, and also for that patient, everyone says give her a nebulizer. When you're uninsured, you can't get nebulizers. You have to be medicated, you have to have funding. So when you have an uninsured population, so the key is to get access to nebulizer, then she could get it through the current system. But I agree, in the resiliency, all those trillions of dollars that are coming down for resiliency, it's coming in your state, it's in Florida. How do we make air conditioning be on that list as equal to when they say plumbing or whatever else they do for the rich buildings?
We have to take it to our policymakers.
Exactly.
This is essential.
That's what
Yeah.
we're hoping that will happen when underserved folks say what they need for resiliency, and it doesn't only mean that it's roads and...
Okay, thank you. Sir?
I'll second
Right.
that. I recently needed to purchase a combi vent Restromat, which is this newfangled thing. It's $150. You don't have to pay for it. My question is to John Bellvez, though. In the National Climate Assessment, is there any interest in discussing the positive impacts of simply trying to mitigate climate change? I'm talking about the psychological impacts socially of living in a society that's taking this issue seriously and is pedal to the metal trying to get off fossil fuels, whether we have climate impacts or not, because it's all baked in anyway. We're going to be suffering for quite some time. The economic benefits of trying to get off fossil fuels, the innovation, and the public engagement that will result from working on this problem, regardless of whether we succeed.
So the short answer to the question is that there's one thing the National Climate Assessment is and one thing it's not. The thing that it is a literature review. So we will review any literature on the subject and incorporate it if it meets quality standards. So I'm not aware of a wealth of literature on what you're talking about, so it probably is not in there. And the one thing that it's not is policy prescriptive. The Global Change Research Program is explicitly not policy prescriptive. It is a research program. It provides the scientific information, and it really tries to draw that line to assure its continuity and its credibility as a source of data. And so what you're describing is starting to, it sounds like, push that line a little bit about what we should be doing, and that's not going to be in the National Climate Assessment unless it's the basis of an evidentiary review for interventions.
So thank you, ladies and gentlemen. Our time has ended. So I want to thank the panel for their presentation.
That last question was actually a perfect segue into our next panel, which is focused on air pollution and some of the policy changes that have been made in the past and that need to be made going forward to address some of the problems that we're hearing about.
Blew my doors off.
Thank you. It's tough to stand between a group of people and a reception, but I promise you we have a great panel discussion, and it will be worth the time. So my name is Lindsay Mosley Alexander. I'm Assistant Vice President and Director of the Healthy Air Campaign for the American Lung Association, and I am pleased to moderate today's panel called Strategies for Progress, Healthy Air, and Climate Change. And the American Lung Association is very pleased to co-sponsor this event. And I apologize for the scratchy voice. I woke up with it this morning. So I have a bottle of water if I have to get it. I promise not to do the Marco Rubio stretch. So when it comes to air quality in the United States, the American Lung Association has been tracking and been very engaged in fighting for healthy air for decades. Our nation has made tremendous progress in cleaning up the air we breathe, thanks in particular to the Clean Air Act. And for the past 19 years, the American Lung Association has published the State of the Air report, assessing air quality across the United States using a simple A to F report card format. During this time, we have seen a significant downward trend in the number of unhealthy air days experienced by millions of Americans, which is good news. So we'll start with the good news. However, despite this progress, still too many people live in areas where the air is unhealthy to breathe, and they remain at risk from air pollution. Our 2018 State of the Air report is due to be released next week. So I'm showing you 2017 data, but as you can see here, 125 million Americans still live in areas in counties that received a failing grade for either ozone or particle pollution, and that's about 4 in 10. Which means we still have a lot of work to do. Sorry, the trigger is happy trigger. And as you've heard, and I will not reiterate in depth, climate change really threatens the progress that we've made because of heat waves and ozone pollution, wildfires, and other factors that are making it harder to continue the progress that we've made. And we've started to see this in our annual report. Which is simply the point of the last slide. And to the presenters, hit the button and let it take a minute. Okay. And then it won't be quite so aggressive. And we've heard a lot today that there are there's an overlap between the sources of conventional pollutant and the sources of greenhouse gases. And given this overlap, one of the points that this panel we want to explore with you, and that the Lancet Commission on Health I think put it extremely well, is that tackling climate change is not only a great threat to our health, but it could be one of the greatest global health opportunities of the 21st century. And in the health community, we can bear that message. And in climate change, there's really the message of hope is critically important. And to be able to speak into dire statistics with a message of hope is something that we can do. And I hope that we will do that. So I'm going to conclude my introductory remarks for the panel there and introduce our speakers. So our first speaker is Dr. Meredith McCormick. She's Assistant Professor of Medicine at the Johns Hopkins School, University of Medicine. Her areas of clinical expertise are many. They include asthma, COPD, general pulmonary diseases, and critical care medicine. And Dr. McCormick also holds a joint appointment in environmental health sciences at the Johns Hopkins Bloomberg School of Public Health. And for each of the introductions, I also want to encourage you to read the full biographies. These are brief. Dr. McCormick.
What was the tip?
Actually, you said escape out and up. There we go. And then that is just hit it once and wait. Okay.
Thank you. Thank you for the invitation to be here today. And in Baltimore, I take care of patients with asthma and COPD and spend a lot of my time doing research about these diseases as well. Let's see if I can. Do I need to put this in a different view? Good. And I think we all recognize that the issue of the health effects of climate change is being increasingly recognized And here, just highlighting reports by the World Health Organization, the National Institute of Environmental Health Science, and my own organization, the American Thoracic Society, as well as the American Lung Association and others. And again, under different scenarios, we anticipate that the surface temperatures near the Earth will continue to rise. And we can look to historic events to think about what the potential health implications of this are. And I think one of the most obvious is the health implications of heat exposure. And here, this is just a historic example from 2003, demonstrating that there were profound impacts of the heat wave during that time in Europe, where estimated death tolls exceeded 70,000. And we know, which has been said before, that everyone isn't affected equally, so that those that live at the extremes of age, children and older adults, as well as those living with chronic illnesses, are more likely to be impacted by the adverse effects of heat. And I was fortunate to work with Brooke Anderson and others to try to understand not only the effect of extreme heat events, but also the effect of just more everyday conditions with increases in heat. And here we linked data from EPA monitoring stations to Medicare data about respiratory hospitalizations, and found that with increases in heat, more representative for what we would experience at different cities across the country, there are associations with increases in respiratory hospitalizations, about a 4% increase in the risk of hospitalization for every 10% increase in temperature during the summertime. And we also found that those living in more moderate climates were more likely to experience increased risk of hospitalization with these increases in temperature. And one of the things that I was curious about just interacting with patients in my own practice is not beyond the population level, but at an individual level, what are the effects of heat exposure? And so in Baltimore City, we did a study of about 100 patients or participants with COPD. And we wanted to understand better the effect of indoor heat exposure and how that related to the day-to-day outcomes that they were experiencing. And we looked at respiratory symptoms, as well as use of their rescue inhaler medications and measurements of lung function. And we put monitoring equipment in the homes and found that in fact, increases in indoor temperature were associated with increases in respiratory symptoms, increases in the need for the rescue medications, and tended to be associated with decreases in their lung function. We also found that among these 100 people, half of the days during the summertime, they didn't leave their home at all. And on the other half of the days when they did leave their home, they only left their home for, on average, 1 to 2 hours. So really spending a lot of time in the indoor environment, so those adaptive strategies becoming even more important. The other thing I spend a lot of my time thinking about is the effect of pollution exposure. And again, turning to a historic example that I think set the tone for understanding health effects of air pollution is the example of the London smog. And here, early epidemiologists were looking to try to estimate the excess deaths created during these several weeks of intense air pollution exposure. So beyond extreme exposures, there's also been a lot of investigative work to look at the effect of day-to-day exposures. And after earlier pollution episodes with extreme events, research turned to average events that looked more at urban areas, and then focusing more recently on susceptible populations. And this is an exposure that I work a lot on in particulate matter, so thinking about dust particles that are suspended in the air. And investigative efforts have provided the evidence of health effects that have then gone on to inform our policy. And under the Clean Air Act, 6 criteria air pollutants are regulated to protect human health, and these regulatory efforts are based on the scientific evidence demonstrating adverse health effects, particularly in susceptible populations. And this goes at the population level as well as the individual level. And this is just an example of the wealth of evidence. I chose particulate matter as an example, but linking outdoor particulate matter exposure to increases, in this case, in mortality. And you can see that these are many different studies that have consistently shown that increases in exposure are associated with increases in adverse outcomes. Here, mortality on the left, all-cause mortality, in the middle, cardiopulmonary, and then cardiovascular. And I could go on and show more slides of hospitalizations and other adverse outcomes. This is an example of a study that looked at children, and I wanted to not just highlight particulate matter. On the left is particulate matter, and on the right is ozone. And what they found was during the warm season, they found independent effects linking these two outdoor pollutants to increasing risk of childhood asthma. So as has been stated, but I wanted to underscore, not all populations are impacted equally. We know that the young and the old are more susceptible. Those with underlying chronic diseases, and I'm particularly focused on chronic respiratory diseases like asthma and COPD, those individuals are more likely to be impacted by the health consequences of climate change. And this has been demonstrated in mortality as well as specific indicators of morbidity, such as hospitalizations and exacerbations. Thinking about the sources of these pollutants, those that are both contributors to climate change and so can be impacted by efforts to reduce, for example, vehicular emissions, industrial emissions, thinking about alternative sources of energy, and then also those that are consequent of climate change, thinking about and this is a photo of California this past year, and thinking about other natural sources that may be occurring more frequently, like the context of wildfires. And finally, ending on a positive note, we have seen, since the Clean Air Act and more stringent regulatory efforts, we've seen decreases in our outdoor air pollution concentrations. And there's increasing scientific evidence that this translates into measurable health benefits. Studies in California have demonstrated that in cohorts of children, reductions in air pollution have led to decreases in bronchitic symptoms in kids, that they've translated to improvements in lung function, looking at adults across the U.S., as well as increases in overall mortality. So preserving the science that goes to inform our policy is critical. And we know that the impact of these studies and the regulatory efforts have led to improvements in our air quality, and these have translatable and measurable health benefits. So continuing efforts to improve our air quality. And with that, I'll try to keep moving so we can get to it. Thank you.
So our next speaker is Dr. Adriana Perez. She is Assistant Professor of Nursing and Senior Fellow at the Leonard Davis Institute of Health Economics at the University of Pennsylvania School of Nursing.
Thank you very much. It's great to be here. I moved to Philadelphia almost 3 years ago from Arizona State University. And my research as a scientist and my work as a clinician, as a nurse practitioner, has been predominantly with older Latinos. And I was very, very surprised that there are a lot of Mexican people in Philadelphia. You know, Puerto Ricans are the the highest Latino group, but I was so surprised to find a lot of migrant, farm-working Mexican immigrants in Philadelphia. So, you know, it's very interesting, and I think that especially when we look at the states that are impacted by air pollution and climate change, those are two states that I've lived in that I could speak to those for sure. And I want to focus on three things. I was asked to talk about the cardiovascular effects of air pollution and recognize, especially here, this second point, the environmental factors that increase cardiovascular health disparities among vulnerable populations, as many have said already, especially in my research and my clinical work, older adults, women, Latinos. And I do think that for nurses especially, you know, being the largest healthcare workforce, this is an opportunity for us to be part of the national movement, take a leadership role. Nurses are in the front lines in many situations, so I think we're in a great position to educate and to empower our patients and their families with environmental health literacy issues. I do want to thank the EPA. Much of this presentation has been informed by a work group that convened in 2016, led by Dr. Wayne Cassio, that focused on preventing air pollution-related cardiopulmonary illnesses in Washington, D.C. So in 2004, the original American Heart Association statement on the cardiovascular effects of air pollution was published, particulate matter, air pollution, and cardiovascular disease. This statement was updated in 2010 and emphasized that traditional cardiovascular risk factors account for the major portion of the risk factors related to ischemic cardiac events. So, that is true. But there is sufficient evidence to conclude that a causal relationship does exist between short-term and long-term exposure to particulate matter, 2.5, and mortality. And the short-term exposures lead to elevated levels of particle pollution and can worsen heart failure, trigger heart attacks, stroke, and some arrhythmias. And these are the patients that I see in our clinic, pretty regularly. And long-term exposure leads to air pollution and can have more insidious effects, such as accelerating the development of atherosclerosis, contributing to premature death. So, despite the major gains that have been made in terms of cardiovascular health, cardiovascular disease remains the leading cause of death in the U.S. since 2011. Now, those improvements and those gains have not been proportionate. We still have communities that suffer disproportionately from risk factors like Latinos. Globally, the second leading cause of illness is household air pollutants from the burning of solid fuels for cooking and heating, as was shown earlier. And while outdoor air pollution causes approximately 3.7 million deaths per year, in the U.S., the EPA estimates that particle and ozone pollution causes about 130,000 premature deaths and about 180,000 non-fatal heart attacks annually. This means that air pollution induced death is on the same order of magnitude as some of these illnesses at the bottom, like Alzheimer's, diabetes, pneumonia, kidney disease. So it's very, very critical to look at, and it remains understudied. It remains underfunded. I wanted to just share this slide because it explains a little bit more, and this is in the American Heart Association statement, the mechanisms that are under investigation but are likely related to the effects of oxidative stress on the autonomic control and inflammation. So what you see here is the biological pathways that link particulate matter exposure with cardiovascular disease. And so where you see the question mark is where there is still some weak or mixed evidence of the mechanism and likely more related to theoretical existence based on the literature. But as you can see here on the bottom, the definite impacts on the vasculature, metabolism, and blood. So I do want to focus on cardiovascular health disparities, especially among Latinos. There is enough evidence to show that Latinos are not only at risk for cardiovascular disease, but also at risk for air pollution related disparities. And it's important for us to look at because Latinos do represent 7% of the older adult population. They're expected to increase to 25% of the population by 2050. And the largest Latino population increases joining California will be Arizona, Nevada, Texas, and Florida. As women age, for example, older Latino women are increased risk for chronic disease, including cardiovascular disease, asthma, COPD. And so when we look at the map of the states that are most affected, again, you could see Southern California. In Arizona, that dark area is Maricopa County, where I lived. And then you could also see Pennsylvania, some counties there, Florida, and even Texas. So indeed, the areas where the highest Latino populations are the areas where you see the burden of air pollution deaths by county. So these are counties that are impacted by stubborn air pollution and that would really be impacted by lowering any standards of what we currently have with the Clean Air Act. And so just, again, just want to emphasize that in addition to these issues, occupational factors, higher rates of density in disadvantaged neighborhoods only contribute to these things. And there is a myth, that Latinos only care about policies that are related to immigration. And while that's true, Latinos care about the economy, care about the environment. So these are areas of opportunity, I think, for us. So Latinos in America are far more likely than the average citizen to breathe polluted air. And you can see here, this is a graph I wanted to share. You have the source here that shows that more than half of America's population lives in communities with unhealthy levels of ozone smog. And again, the League of United Latin American Citizens and the National Hispanic Medical Association published this a couple of years ago, and they showed that 51% of Latinos are more likely than non-Hispanic whites to live in these counties. So you could see where some of the disparities then fall. So this is significant, again, because of the growth of the population. Air in many Latino communities violate the air quality standards for ozone smog. And so here's an opportunity for advocacy, especially for bilingual, bicultural nurses. I'm a proud member of the National Association of Hispanic Nurses, and this is an issue that we've taken up in terms of policy and advocacy, because we do see the effects of these issues when we are in the emergency room and community health centers. And so I do encourage my colleagues to work in partnership with other healthcare providers to address this issue. And so some of the issues that the third point is that I do want to emphasize the implications, especially for nurses. The work group from 2016 highlighted the Million Hearts 22 framework that includes information on improving outcomes for priority populations. And basically, the Million Hearts campaign framework is focused on two things. One is to increase cardiac rehabilitation participation by patients who have had a heart attack or a stroke, and two, avoiding exposure to particulate matter, 2.5. And so what these are great recommendations, but what are we doing in order to increase participation in minority communities? Latinos remain the highest uninsured group in this country. So what additional steps can we do to include and involve and think about frameworks that include the family when we're educating our patients, especially in communities where that is a very important cultural factor? As a cardiovascular nurse, a lot of my teaching is on increasing physical activity. That's where my research is. So how do we tell patients that, you need to be more active, you need to walk outside in your neighborhood to be more active, when there's a conflicting message here? So how do we provide environmental health literacy, not only in Spanish and the appropriate language, but also in ways that we can relate the cultural values of the communities that we're working with, empowering them to reduce such exposures? And again, I just came from a focus group right now in Philadelphia where we were talking about increasing engagement to research. And the community participants that were there, are interested. They have a high interest in being educated and receiving this education, but talked about that this information hardly ever reaches them, and when it does, it's not in the appropriate language or in ways that they can understand it. So messaging must reflect the linguistic and cultural needs of patients. And what I've used a lot and have found to be very effective in terms of research is promoting community engagement through a participatory framework to involving community leaders. Only 5%, for example, of nurses are Hispanic or Latino, yet the highest minority growing group is Latinos. And so how do we work with promotoras de salud, community health workers to reach the populations that we need to? So engaging our consumers into climate change and air pollution health literacy is very important. And again, as others have said, this remains understudied, underfunded. And nurses especially, I think, I see very little. I'm working with students now at the University of Pennsylvania. We conducted an environmental scan of the top universities and education that we're providing to our undergraduate nursing students. And it's very, very slim to none. There are very few schools of nursing that embed climate change health. And that's why, I thank the Alliance of Nurses for Healthy Environments, because they have great tools. Those things have to be embedded in our curriculum across undergraduate and graduate levels. So again, nurses must advocate for maintaining and building on the Clean Air Act. And I think that, as the American Nurses Association has said, air pollution creates more patients, and prevention is the only real effective and long-term treatment. The National Association of Hispanic Nurses, we published a statement in 2014 or 2015 that, again, commended the EPA, the Clean Air Act, on its advancements and continuing efforts, but emphasizing that additional work remains to be done to address cardiovascular health in communities that are especially impacted by this disease.
So next we're going to hear from someone you heard from this morning, Dr. Ed Maybach, communication scientist right here at George Mason University, who is also an expert in the uses of strategic communication and social marketing to address climate change and related public health challenges. And he's going to talk to us a little bit about the opportunities from a communications perspective of linking up air pollution and climate change and being strategic when doing so. So, Ed?
Thank you all. Thank you, Lindsay. So like almost everybody here, I am a health professional, first, foremost, and always. Unlike almost all of you, I am also a communication scientist. So I spend a lot of my time trying to understand what members of the public know about important public health issues, what we can share with them that we know that will be of most value to them, and how to essentially start and foster those conversations in a way that will bring about important societally scaled solutions. Climate change is a tough issue. Air pollution is a tough issue. Lots of pain and suffering all the way around, only getting worse going forward. But I am here to say I am absolutely firmly convinced, based on the data, based on my data and anybody else who's looking at this, that we have important information to share. So Dr. Perez just gave us a wonderful anecdote of that from some focus groups she's been involved in Philadelphia. I have been involved in testing, not necessarily, I don't get necessarily in the opportunity to be face-to-face with people around the country, but I continually collect data with people around the country to try to understand what they know about climate and health, what they know about air pollution and health, what they think about the solution sets that we have at our discretion and which ones they most want to see us go forward with. We have the opportunity to wage a public health communication campaign that is absolutely going to change what is currently a pretty dismal looking future into a much brighter future. So that's my fundamental message to you. Now let me unpack that just a little bit. Every successful public health campaign in human history has always featured simple, clear messages. Really important that we take all of the complexity of what we know and we render it simple so that people have the opportunity to understand it, to think about it, to incorporate it into their own knowledge, and to share it with the people they know and love. Simple, clear messages that must be repeated often by a variety of trusted voices. We are those trusted voices, and we have some simple, clear messages that my research shows makes a big difference in creating the conditions that will eventually absolutely necessitate that the U.S. Congress move forward with real, meaningful climate and air pollution solutions that will protect our citizens now and in the future. So let me talk just a little bit about what some of those simple, clear messages are. Our medical alert report, which Mona Sarfati and a number of others have talked about today. This was the report that we used to launch the Medical Society Consortium a year ago. I know that most of you like this report, but what most of you don't know about this report is it was the product of a boatload of messaging research. We spent a lot of time figuring out what the public knows about climate and health, which is almost nothing. We spent a lot of time simplifying all of the vast complexity in the National Climate Assessment that John Bellvez talked about, which is a whole lot, but it had to be distilled into just a little bit, a set of simple, clear messages, and we tested ways of conveying those messages. This report is really the distillate of that. It's an incredible product. It is heavily tested. The messages here, we know, are seen when people are exposed to these messages. They find value in them. More importantly, they respond to them in a way that indicates much greater understanding of and support for societal solutions, most especially accelerating the inevitable transition to clean, renewable energy so that we can have cleaner air and cleaner water. Secondly, also perhaps even more importantly, not only is this engaging to members of the public, but it's engaging to members of the public across the political continuum. Conservative Americans see at least as much value in this information as liberal Americans. And that's hard to do, and that's important, because reducing the political divide on the issue of climate change and on the issue of air pollution is really job number one for us, and we are just the people to do it. Health professionals understand how to make the issues personally relevant and take them out of the political domain that makes most Americans profoundly uncomfortable. Just to elaborate on the point that Lindsay foreshadowed, and actually to do so, any of you who were here this morning and saw Mark Jacobson's slide, which showed that many more Americans and many more people around the world are interested and supportive of clean energy than are even convinced that climate change is bad for us, or even that it's real, well, that only goes to make the point that there's lots of reasons to like clean energy, to support clean energy, to support accelerating the inevitable transition to a clean energy future, because it's just a good deal for us all the way around. Most Americans have an intuitive sense of the fact that dirty energy is bad for our health. It pollutes our air, it pollutes our water, it harms our children, it harms our parents, it harms us in a variety of ways. Recently, we have been building on I'll call it an emerging evidence base over the past decade, showing the neurodegenerative, the neurotoxic, the neurodevelopmental, and neurodegenerative impacts of fossil fuel use, fossil fuel combustion. This is an entirely different way of having a meaningful conversation with members of the public, a way of not necessarily even talking about climate change, but talking about the root cause, dirty energy. And what we've learned is also incredibly good news. When we give people information about the ways in which using fossil fuels harms our children's brains, harms older adults' brains, harms particularly the brains of people in vulnerable population who are exposed to more dirty air, people say, wow, I didn't know that, but that actually makes a whole lot of sense to me. That is exactly, that sort of confirms all of the things I have always believed about fossil fuel, that it just seems like we have better choices now that we're in the 21st century. And it absolutely people who we have exposed to these messages, they say, they respond to it in much the same way as they respond to climate and health messages. They say, I will share, I'm so happy to know this. This is going to absolutely, this is information I am absolutely going to share with people that I know and love, which is really important because the most trusted people in anyone's lives are the people closest to us, our friends and family. And they say that it helps them understand why we need to accelerate that transition, that inevitable transition to a clean energy future. And again, like the climate and health messages, it has this wonderful depolarizing effect. It doesn't strike people as politics, it strikes people as common sense that we should be moving away from fossil fuels as quickly as we can. Last point, this is research still in process. We're we're collecting data with 1,800 Americans, give or take, to find out exactly how best to share what we know about climate and health and fossil fuel and health. And so this is preliminary. The experiment isn't even yet done, but I took a little peek at what we were finding. And what we found is when you start the conversation and make it about clean air, make it about the benefits, about the harms that air pollution is doing to us, not only the harms that are very well understood, the cardio and pulmonary harms, but also the neurotoxic harms, it actually creates an opening for people to also hear about the harms, the health harms of climate change. So we have at least 2 really important conversations that we, through our collective trusted health voices, have the opportunity to start in America. And I'm convinced, based on my data and any of the other relatively small number of investigators who are looking at this, that this is the conversation that can push the public to the point of demanding the kinds of solutions that really will help us create a better future, rather than looking at a long and dismal future that we are currently staring in the face. So please join me in using your trusted voices to share what you know about climate and health, what you know about air pollution and health, why you know that fossil fuel is best left in the ground. Thank you.
As I switch these slides, I'm going to ask you to raise your hand if you want to be on the side of common sense, health protections. I don't see any hands raised. Come on. Okay, everybody wants to be, it's like motherhood and apple pie. I mean, I think what you're teeing up at is that we collectively, health voices, can be a part of a transition that needs to happen in this country. And it needs to happen at every level of government. And we're going to talk first about local initiatives. Brendan Shane is going to join us. He's the program director for Deadline 2020, the C40 Cities Global Initiative to adopt and deliver ambitious climate action plans for all 92 member cities that are consistent with the Paris Climate Agreement. So please welcome Brendan. Oh, I'm sorry. I thought I pulled it up.
No, sorry. Thanks, everyone. It's really exciting to be here and to follow Ed's comments. I think that I've been in conversations, in particular with the Climate for Health initiative through Eco America, which is an organization that has, a few sectors they work closely with. One is health, another is city leaders and mayors. Basically, exactly what Ed just said is that. In many instances, mayors are, go up a lot higher. In many instances, mayors are trusted voices, in large part because when you get down to the level of a city, the rubber hits the road, literally. You have to get stuff done. Politics is not the same. I mean, there's always politics, but it's different than even state level politics for sure, and obviously national level politics. And so a number of these, what I think is most exciting, or one of the many exciting things about the effort you're bringing together is that it's not only bringing the medical societies together, but then the affiliates that really do reach out, because we're looking more and more at how these trusted actors together can move. It shouldn't all fall on the shoulders of the doctors. It should be the doctors standing with the business leaders, standing with the mayor, standing with the religious leaders of the community, to ask and demand just what Ed was just saying. So I'll give you a little bit of an overview. Perhaps we're a little bit of an oddball here because we're an international organization, and actually many more cities outside the United States than inside it. But to give a sense why I'm here, I think in part we're a little bit unique among city organizations in that we are dedicated to climate. And we're very much sort of data and science driven. So we actually have research elements within our organization that are focused right in on climate impacts, the causes of climate impacts, and as I'll mention here in particular, how to address those, how to identify the benefits, make the case for climate action in a way that's going to drive the solutions we want to see. Also, I think in the United States we have 12 cities. You know all of them. And these mayors, I think, are very much leaders of the resistance today. When you've looked at responses to, poor decision-making at the federal level and state level, you'll see mayors from New Orleans, from Houston, from Chicago, from Los Angeles, from Portland, from Boston, from Washington, and New York City, all our members that are some of the first to come out and say, this is a bad idea, this is a dumb policy, and we're going to do it differently at the city level. One last sort of general comment is that our sort of organizing philosophy, and we're a network of global cities, one of the organizing philosophies for us is that as we drive to solutions around climate, increasingly the people of the world are in the city. And by 2050, you'll be at 3/4 plus of the people will be in the city. So the theory is you cannot solve the climate crisis unless you can implement the solutions in the city context, actually make it happen. The new transit, the new energy, the cleaner energy, the better health, the better green space, the cooler cities, lower temperatures, all those things have to actually be implemented at the city level, or it just isn't going to happen. So mayors and other city leaders fall in that sort of critical place of the people have to make it happen. I'll see if I can move on. So basically our overview is we're in actually 90 cities now, even though we're still called C40, but they represent a big chunk of population and also a disproportionate chunk of the global GDP. So these cities help drive lots of decision-making and economic decision-making in particular. Our business plan, what we're about, is moving our cities to take the Paris Agreement from aspiration, the targets and the goals that were set, to action. And so that means across the bottom here, we're literally connecting them in a networking way. We're aligning them around what the data shows are the deadlines. And this is the work I do under the heading of Deadline 2020, is we have to peak emissions and start driving down quickly by 2020. We have to do it faster than anyone really expected us to. And we need to get to net zero communities, zero carbon communities by 2050. And then now increasingly moving to collective impact. Once we know where the science tells us we need to go, how do we get there? And how can mayors together, and then mayors with critical other partners, get us to where we need to go? Whoops, sorry. I think it's the same quote from Lancet that you had, so I don't have to leave it up here very long. And I don't have to tell you that climate and health are inextricably linked, and delivering the health you need is very much tied to climate. Oops, sorry. I also don't need to tell you that mayors know this. And so you see headlines like these, mayors like Mayor Khan of London. I mean, these are real issues. In some places, they are the issue driving much of local policy. Disastrous levels of air pollution and deaths measured in China and other places in the hundreds of thousands per year. So this is a political priority for our organization, for many of our leading mayors, and our chair, who is Mayor Anne Hidalgo of Paris. And it spans all across the globe, and very much so for our U.S. cities. So we have a variety of research elements, and I'm sort of here representing Rachel Huxley, who's our research lead, and others that work on what the data is showing. But we're very much focused on taking the information we have about the climate problem and starting to quantify the benefits. Sort of a global approach to benefits measurements that allow us to essentially make the case. Why, this is one reason, health is one reason. There's job growth opportunities, there's community development, and a whole range of others that are going to, that we want essentially to enable cities to really effectively and efficiently measure and understand the wider benefits of climate action, just to keep the train moving, provide the data and the evidence that they need to act. Yes, so making the case, it's data points, just a few selected ones like this, that we had a number of cities sign on this, end of last year, to what's called Green and Healthy Streets Initiative. So this is rapid transition to electric vehicles, creating low emissions or zero emission zones within the cities, pedestrian and other. Extrapolate the information about those approaches, and you see you could prevent 45,000 premature deaths across just our member cities. You see information that starts to link specific solutions like cycling, also tied to walkability and more mobility, saving carbon and saving money. You see the shift to renewables that's been mentioned, and clearly it's very at the top of many of our mayor's lists of actions to pursue, saving potentially massive amounts of money and preventing really significant premature deaths just by 2030. And then these numbers continue to grow. The benefits of these actions continue to grow as you go out to 2050. So, sorry, oops. Just an example of how we are approaching this. I'm really not doing this right. Yeah. So we have a number of pilots that are now getting more and more detailed over time. So in terms of this effort to look at what are the climate benefits of various actions, such as retrofitting buildings, cycling and walking, bus rapid transit, solar thermal, PV retrofits, and urban forestry, starting to take select cities that partner with us and with other universities and organizations to really quantify and measure the benefits. Diving in last year a bit deeper with sponsorship from Novo Nordisk and from Johnson & Johnson, who I saw as a sponsor here today as well, which is exciting to see. So bringing in cohorts of cities to really dive deeper. Where's the data? What are we seeing around and what can we measure as benefits of walking and cycling approaches, or targeted air quality policies, or air quality solutions like FFS, we call fossil fuel streets, really great acronym. Cook stoves, low emission zones, zero emission vehicles, things like that. And so start to see data, in particular from the air quality. I must be pointing at the wrong thing. Well, you see around walking and cycling, you see new bike share programs and new mobility solutions, safer crossings, and ideally what you want to see everywhere is cities proving concepts and then state, or in this case national funding, following the solution, right? And then around air quality, you see the ability to take information around the different solutions, look at those applied to our set of cities, and see that you have potentially 30 or 40 million citizens affected by applying just this few solutions across our network. Also, ideas being exchanged city to city, and I'll come to this next, because as many of these things are starting in global cities that have, the worst, the worst cases of air quality and other impacts, they're very much moving to Europe and to the United States, and so we have our cities now starting to look at the examples, policies, and solutions that are being applied elsewhere. Oops, sorry. The last thing I wanted to mention, and this is a bit, just about the cities in general. Not that many people, I think, tend to think, particularly in regulatory context in the United States, where it's sort of a federal state county thing. You don't always think about, the role of the city. Sometimes the city is the county. But anyway, I think you increasingly have mayors who are trying to push the limits, and particularly in the sort of resistance mode, try to identify solutions that weren't thought of before. This is one that came from global cities, but is now being looked at in the U.S. So last year we had this event called Air Evolution. Basically the idea of cities with some of the worst pollution, whether it's Paris or Seoul or London, Bangalore, taking back some authority, implementing their own on-the-ground street-level testing, implementing their own vehicle emission testing scenarios, and starting to use their regulatory hammers to say, these vehicles make the cut, these vehicles don't make the cut. Or what is often the case, vehicles that showed this certain emissions at the federal testing level aren't proving to actually have that level of emissions at the street level. And so you see cities starting to look for new opportunities to make real change, to say, no, we need a better monitoring scheme for monitoring instruments around our city. London has an RFP out right now to do a much more detailed street-level monitoring system for air quality to then help identify hotspots. And then taking that information also to look at ideas like vehicle regulation that typically have not been done by cities. And the last one I'll mention is developing pilot for us as well with Los Angeles, but a number of the U.S. cities are engaged in this as well. So this is essentially looking sort of broadly under the authority of Mayor Garcetti released Plan LA, or the LA Plan, I can never say it right, a year or so ago, which was a sort of umbrella climate plan. But now taking work there as they move to their second iteration of the plan to dive deep on air quality issues. So we put staff on the ground there that are starting to pull in the data, but then looking across the suite of powers and actions that the city can take to assess existing programs and policies that very much look at health as a driver for climate actions. Also targeting new options that are coming from global examples or from around the United States. And then very much looking at prioritizing climate actions that are linked to health outcomes. Again, sort of mimicking this idea of higher resolution air quality monitoring on their streets, targeted use of clean vehicles in certain areas, low emission or zero emission zones, and other solutions like that. And I think that's it for these examples, but look forward to discussion and encourage you all to get in touch with your mayors.
Thank you, Brendan. And I'm going to switch back to a slide deck from the beginning because Mona asked me, I think we've heard a lot of snide remarks or snark about federal policy and the opportunities available to us these days. But I'm going to throw a couple of slides up and talk about federal policy for two reasons. One is it's critically important context in which we are operating. Two, many of you are going to go talk to members of Congress tomorrow, so I'm going to preview your ask. And three, well, I said 2 points, but I'm going to add a third one. We actually have a lot to lose on the federal policy front, and that is something that we just can't go without saying in a conversation about solutions. We want to move forward, not backwards. So you heard reference this study on the costs and benefits of the Clean Air Act as a key policy. It is both a policy to reduce pollution in the air that we breathe, and it is the only existing federal tool that we have that allows us to limit carbon pollution from major sources like power plants. And there, I'll get it full screen for you. An incredibly powerful set of benefits that accrued in 2010 and were projected for 2020. I think, Adriana, you mentioned 160 premature deaths avoided in 2010. That number rises to 230,000 premature deaths avoided in 2020. And it doesn't count a whole slew of federal policies that were adopted since 2011. So, for example, EPA adopted mercury and air toxic standards to limit neurotoxic mercury and other toxic pollutants from power plants that would estimate help prevent 13,000 premature deaths. EPA strengthened the PM 2.5 standard and the ozone standard. EPA and NHTSA adopted greenhouse gas standards for cars. And EPA adopted the first and only national program to limit carbon pollution from power plants, which is a major driver of climate change. And in that process, predicted that it would help prevent each year, once fully implemented, 4,500 premature deaths. These are not insignificant numbers in the fight for healthy air and the fight to address climate change. The little asterisks here really see my previous point about things that are under attack right now by the current federal administration targeted for rollbacks. And these are things that it's critically important that we make our voices heard, especially targeting the agencies that have proposed the rollbacks. For example, the Clean Power Plan is still in an open comment period. The deadline is April 26th, so it's not too late to make your voice heard in support of maintaining the Clean Power Plan in opposition to repealing it. So I just wanted to flag that there are opportunities, and you've seen that many of the sources of pollution of both of these pollutants, especially vehicles and power plants, can be addressed through solutions that both improve health and address climate change. And I think, I don't know how much time, Mona, since we were behind schedule, you would like for us to take for questions. Okay, let's take 5 minutes for questions, and then we'll preview the ask, and then we'll wrap it up and get on to the reception. How's that sound? Okay, so what questions do we have? And I think there are 2 mics in the back of the room as well. All right. Okay, go ahead. And there's a mic right up in front if you want to make an effort or just project your voice. Oh, okay. Okay, thanks, Mona.
Yeah, there
okay. The data the study you were citing on heat data, and was that apart from air quality effects? So just independently, heat was causing an increase in asthma and COPD?
That's a great question. That was actually something that I didn't expand on. So we found an independent effect of heat, but then we also found that in homes where there were increases in particulate matter, indoor concentrations, the effect of heat was exaggerated. So another main finding of the paper was that there was a synergistic effect of heat and indoor air pollution causing exaggerated worsening of respiratory symptoms for people with COPD, as well as the need to use their rescue inhaler. And that was a study funded by the NIEHS.
Thank you.
One of the things we talked about earlier is beginning to talk to patients about climate change clinically. And I wondered if Mr. Maybach had any material on their website that would be a shorthand or something heuristic we could use in the clinic and begin as we start to go out and talk to more clinicians as ways to kind of get into that conversation with patients.
It's a great question, this is subject to revision as the consortium moves forward, but when we launched the consortium last year, our operating assumption was that the point of greatest leverage for health professionals was essentially to speak to the public in the most public fora possible, as opposed to speak to their patients, in the exam room or wherever, simply because of all of the pressures, the time pressures and otherwise in the clinical interaction, and simply because of the numbers when you get in front of the media or get in front of a town hall meeting or what have you. So the messages, we do have absolutely identified a set of 5 key messages, and then all of the backup information to elaborate on each of the 8 sort of categorical impacts of climate change on human health. Each of those 8 impacts are expressed as essentially in 150 words, answering 3 questions. What's happening to our climate? How is that harming our health? Who is being harmed the most? So we haven't thought through yet, and with your encouragement, maybe we will think through. If you all think that's a good idea. Oh, I'm sorry. I'm like operating on old assumptions. Mona is telling me we do have that. Mona, you want to come to a microphone and share what you know? Strike everything I said about we don't have that, although we do have this.
So if you go to medsocietiesforclimatehealth.org, which is the website of the Medical Society Consortium on Climate and Health, we do have materials for patients. They've been developed by a variety of different groups, some by Moms Clean Air Force, some by the American Academy of Pediatrics, some by other organizations, but they are posted on our website, which is acting as a clearinghouse for some of these patient education materials, and we will have more as time goes on. medsocietiesforclimatehealth.org, which is our website.
Can I just say that in psychiatry, we're working on this to figure out ways to address our patients, because we're having a lot of patients reporting, therapists who are reporting their patients are expressing anxiety. So we're doing actually a workshop next month at the APA meeting about how we want to encourage therapists and clinicians to ask their patients to be thinking about it. What impact is climate change having on you? And then to launch these kinds of addresses.
Thank you.
Go ahead. Okay, so so that the people who are on live streaming can hear that, what Dr. David Pollack just said was that the American Psychiatric Association is having a meeting in New York next month, I think, actually in mid-May. And one of the themes there will be helping psychiatrists to work with patients to identify their own anxiety about the changes in the climate and to raise the sensitivity of psychiatrists to the issues that people may be facing as they become more anxious about the impacts of climate change.
Thanks, Mona. You want to just stay up here? We'll probably wrap in a minute. Are there any other questions? Oh, there is one here. Do you want to come to the microphone, please?
Dr. McCormick, have you seen any acute pulmonary effects of ozone on people who don't have pulmonary problems but may be outside working all day, like manual laborers?
That is a good question. I think sometimes it's hard to disentangle what an acute, in a clinical setting, what an acute effect of ozone might be, and to try to really specify that exposure in a given individual. But we know from population data that there are effects of ozone, and then certainly we see a constellation of effects of heat and air pollution, and when when both of those factors are in play, that we see patients complaining of increased symptoms. And so sometimes it's hard on an individual level to be able to specify in a clinical setting what an acute effect of ozone is.
Thank you. Are there any other questions? Okay, let me take 2 minutes to preview the ask for tomorrow's meeting with members of Congress. So this is an educational day to go and educate Congress about the health impacts of climate change, to share stories of your patients who are impacted by the various adverse effects of climate change, and to make a specific and clear, unified call to action, asking members of Congress essentially to support measures to reduce pollution from dirty forms of energy and to switch to clean, renewable energy. This is a more generic ask than many of you might have made in the past when you've been asking about specific legislation. But right now we're not in a place where at the federal level we have an opportunity to move a specific piece of legislation, but it is more important than ever that health and medical professionals get into member of Congress's offices, make your voices heard, share your stories, and urge Congress to move away from dirty energy sources of the past and to embrace and make the switch to clean, renewable energy. So that's what we're asking you to do tomorrow. This is not the only time you will have a chance to interact with this. In fact, we're going to have a bit more time to talk about that and to do some training before those visits tomorrow morning. But I wanted to encourage you to think a little bit about this, especially to think about a patient story that you might bring into that conversation with your member of Congress and your senators tomorrow. If you are not able to join us, the last thing I wanted to do was to invite you all to add your name to a health professional's declaration on climate change, calling for bold action to address the challenges that we have been talking about all day today. And to add your name in support, we share this with members of Congress periodically. We share this with the press. We also share it with the agencies. So it is a tool for you to make your voice heard. You can sign up at our booth. I think, although the booths might be closed by now, Lung Association staff, please raise your hands. There are a few of us in the room. You can give your business card initialed to anyone whose hand is up right now, or look online at lung.org/climate-declaration, and we'd love to have you join us there. So with that, I think we wrap our session and turn it over to Mona for where the reception is. Thank you.
Okay, well, thank you, speakers, for that interesting panel. And now it's my pleasure to wrap up this meeting by saying that I think what we've heard today is just a kind of astonishing breadth of new developments to watch. So many of us here in the room have spent a great deal of time thinking about climate change over the last 5, 10, some of us even 20 years. But what we heard today were a lot of new developments that are now on our radar screen that we can watch, keep track of going forward. Early in the day, we heard about the potential to go to 100% renewable energy, the ultimate solution to the climate change problem. We heard about the Lancet countdown and the indicators that are now available to us that we will be able to follow on a year-to-year basis so that we have some actual concrete sense of what is happening worldwide because of climate change. We heard about a new term, mega disasters, which we have actually seen in the last year in Puerto Rico and in other places as well. We have heard about what's going on at the state level, what's going on in the world of education, in medical schools and in nursing schools, and in reaching out to the public to educate the large public out there about what we know, that climate change is impacting health. We got updated about the National Climate Assessment process and what we're learning from that. And then finally about air pollution. And running through all of this is a really strong undercurrent of two themes. One is the regional impacts and how regional impacts vary, but they're all part of the larger picture. And the other is about the social determinants of health and how vulnerable people will suffer first and are suffering first, but that this is a problem that will affect everybody and is already affecting Americans across the country. And so I'd like to thank our speakers for sharing their wisdom with us today, thank the audience for bearing with us over the course of the day so that we could track all of these developments, and now invite you to come and relax and spend some time talking to your colleagues and friends and having some refreshment at our reception. And I hope you'll come back tomorrow morning when we have two vitally important sessions about solutions to climate change, and then we will go to Congress and share what we know with our legislators there on Capitol Hill. So thanks very much.